everybody east of Thunder Bay, and good morning to the west. Welcome to the last day of Canadian Patient Safety Week, the annual campaign that started in 2005 to inspire extraordinary improvement in patient safety and quality. Working together, we can all help reduce the impact of the silent epidemic that claims 28,000 lives every year. My name is Christopher Thrall. I am the Communications Officer with CPSI. I would like to welcome you on behalf of our technical host, Barb Lafort from CPSI, and also on behalf of our sponsors for Canadian Patient Safety Week, Gojo Industries, and Health Pro. We will be hearing from a series of outstanding speakers today who will each address the silence that impacts our healthcare systems. If you miss part of this webinar or want to share your learnings with others in your team or organization, please know that it is being recorded and will be available on our website within the next week. Please write your questions in the Q&A box on your screen or chat them directly to me, Christopher Thrall. They will be compiled and provided to our speakers at the end of the call. If you run into IT difficulties, please connect with us in the chat box and we would be happy to assist. I keep mentioning silence. This is because we are facing a silent epidemic, one that most Canadians don't even know exists. At some point, every one of us will be a patient in the healthcare system. 1 in 3 Canadians has suffered from preventable healthcare harm, and yet we still don't talk about it. If we do nothing, 1.2 million Canadians will die from preventable patient harm in the next 30 years. During this year's Canadian Patient Safety Week, we are launching a new theme. We ask you to help us conquer silence. This silence exists between patients and providers, between colleagues in healthcare facilities, between administrators in different regions, and between the public and policymakers. We want to teach people in Canada that if something looks wrong, feels wrong, or is wrong, we need to speak up in the moment. Here are 3 things each one of us can do right now to help spread awareness about the 3rd leading cause of death in Canada, preventable healthcare harm. 1. Your voice has the power to save lives. Donate your voice today by recording your healthcare harm story and share your advice to help others learn from your experience at ConquerSilence.ca. 2. Listen to the new episode of our award-winning patient podcast to learn how to conquer silence and what we can do to stay safe. Download it at PatientSafetyWeek.ca. And 3, participate on social media using hashtag ConquerSilence and speak up for patient safety. Together, we can save lives. By the end of this webinar, you will understand mandatory reporting in the context of patient safety and learn the regulatory requirements. Plus, learn about educational supports for mandatory reporting. We can work towards conquering silence together. I believe it's now high time to welcome our first speaker. However, I would like to state that I will be breaking in to call attention to the last minute allotted to each speaker. I hope not to interrupt, but with the caliber of speakers we have today, we don't want to short anyone for time. Now it is my pleasure to introduce Mr. Mark Mess, the Director General of the Marketed Health Products Directorate at Health Canada. His team is responsible for the monitoring of the post-market safety and effectiveness of health products. Welcome to the webinar today, Mark.
Thanks very much, Christopher, and good morning and good afternoon, everyone on the line. As Christopher has indicated, my name is Mark Mess, and I'm the Director General of the Marketed Health Products Directorate here at Health Canada. I want to thank the Canadian Patient Safety Institute for the invitation to speak today. As you are all aware, adverse drug reactions and medical device incident reporting are critical in assisting Health Canada in identifying and responding to safety issues associated with health products. In Canada, reporting of ADRs and MDIs to Health Canada by manufacturers and hospitals is mandated through regulation. Volunteer reporting by healthcare providers, healthcare institutions, and the public is also strongly encouraged. This webinar will discuss new requirements for hospitals across the country to report all serious ADRs and MDIs to Health Canada within 30 days of being documented at the hospital. The new mandatory reporting regulations will help ensure that there is sufficient data to detect safety problems that lead to serious harm, death or life-threatening situations or hospitalization, or have the potential to lead to serious harm in cases of MDIs. The central objective of the new regulations is to reduce the risk and better protect the health of Canadians by improving the quality and increasing the quantity of serious ADRs and MDI reports. Monitoring ADRs and MDIs is a core part of our health product regulatory regime. This real-world evidence improves Health Canada's ability to assess and monitor the safety, efficacy, and effectiveness of health products. A number of activities are being undertaken to support hospitals through this change and facilitate their ongoing reporting under this new system. Health Canada has partnered with patient safety organizations such as the Institute for Safe Medication Practices, Health Standards Organization, and the Canadian Patient Safety Institute to assess the needs of impacted hospitals in developing training material to support hospitals in their identification and reporting of these events. Recognizing that improved reporting will not necessarily be realized by regulations alone, Health Canada is carrying out a significant number of engagement activities to raise the level of awareness about the importance of reporting and developing products and tools. Infographics, adverse reaction trend reports, promotional materials, webinars such as this, on-site presentations, and the such, to provide reporter-specific feedback on the actions taken to reinforce reporting. The department is also investing in IT solutions and systems to optimize our data solutions internally, allowing hospitals to report through their existing or preferred IT platforms, minimizing investment and disruption for hospitals. Thank you to today's participants for your dedication and engagement in the safety of health products and patients. I commend you for all your efforts towards patient safety. Thanks very much, Christopher.
Thank you so much, Mark, and thank you so much for your comments. Thank you for joining us. I do just want to comment that just in case some people aren't familiar with the acronyms, ADRs stand for Adverse Drug Reactions, and MDIs stand for Medical Device Incidents. Our next speaker is Marianne Murray, a member of Patients for Patient Safety Canada. Marianne, hang on, I'll just move the slide forward. Marianne has been a part of the mandatory reporting team since the beginning and an advisory panel member for the development of education to support the mandatory reporting regulations. Welcome to the webinar, Marianne.
Thank you. Thank you very much for inviting me. I'm delighted to be part of this. I'd like to start talking about the purpose of Vanessa's law. The purpose of Vanessa's law is to improve patient safety. That's a full stop. It's about reporting, analysis, and improvements to create a safer healthcare system for everyone in Canada. It's a wonderful thing. Can you move to the next slide? Hello, can you hear me?
Yes, I can hear you. We have the Protecting Canadians from Unsafe Drugs Act slide. Next one.
Yes, thank you. And this law will improve Health Canada's ability to collect safety information. It'll allow the analysis of data to help take appropriate action, such as product recalls or label changes, when a serious health risk has been identified. And it will increase transparency by sharing more information, which we could all use, helping us all work together. I'd like to point out that for 50 years in Canada, we've had a national voluntary reporting system, but encouraging reporting is not enough. Our system has has not covered all of the reports that it could have. And so now, with every hospital in Canada reporting adverse drug reactions and medical device incidents, we'll know what's happening across the country in hospitals. These actual report numbers and severity of incidents will help support funding requests for safety improvements. So simply put, this legislation, I believe, will help create a true shift to safety. So let's talk about Vanessa and why it's called Vanessa's Act, or Vanessa's Law. Vanessa Young was a 15-year-old who died in 2000 as a result of taking a prescribed drug. The drug she was taking had already been linked to 80 deaths in the U.S., and it was pulled from that market. It was subsequently pulled in Canada as well, but not soon enough for Vanessa. Vanessa's father, Terrence Young, has worked tirelessly to create improvements, and in 2004, Vanessa's Law was passed in the House of Commons with unanimous support. That's not that common in our country. Its implementation on December 16th of this year will be a key step in improving patient safety. So where do I fit in? Next slide. In 2002, our 22-year-old daughter, Martha, also died suddenly of an ADR. And then a cone of silence descended, and there was no reporting that took place. To be clear, there was no sharing, no learning, no recommendations for improvements. All too often, ADRs are seen as isolated incidents or patient or provider errors, and there's a limited focus on improving patient safety for others. In Martha's
1 minute,
case,
Marianne.
Sure.
Thank you. Yeah, Marianne, 1 minute, please.
Okay.
Oh, that means you have 1 minute left. If you could please continue your presentation.
Okay.
Thank you so much.
Okay. In Martha's case, once the reporting and analysis happened, there were 16 provincial recommendations and changes that took place. With the implementation of Vanessa's Law, I expect to see many improvements occur nationally. So my personal journey has been a catalyst for my joining Patients for Patient Safety Canada, working with CPSI, working with ISMP, and globally working with the World Health Organization. We're all interested in stronger and more robust reporting systems. We all have a role to play. Last slide. And I'd like to talk about, from my point of view, my role is in public awareness and understanding. And with the help of ISMP and CPSI, we've pulled from the 4 educational modules and created one module on Vanessa's Law for a public and patient audience. The module uses plain language, it provides tips on recognizing harm, and it promotes patients as partners. The responsibilities and benefits of Vanessa's Law are explained, and information is provided to assist the public to report themselves, especially if an ADR or MDI happens outside of a hospital setting, such as in a nursing home. You're welcome to use these modules and share it with patients as well. You'll find it, along with the other 4 modules, on the CPS website under Tools. Thank you for allowing me to present today.
Excellent. Thank you so much, Marianne, for sharing your story. Your experience and the experience of so many people like you is the reason we're here today. Our next speaker is Marianne Darpino. Marianne is the Senior Director of Patient Safety Improvement and Capacity Building at the Canadian Patient Safety Institute. Marianne is also the CPSI Executive Sponsor for the Joint Venture Partnership, together with Health Canada, Sylvia Hyland from ISMP, and Feria Bacchus from HSO, in the development of education to support the mandatory reporting regulations, which you will hear more about. Thank you so much for being here today, Marianne.
Hello, everyone, and thank you very much, Christopher. I'm delighted to spend just a few minutes with all of you highlighting reporting in the context of patient safety. So we know that underreporting and poor quality of reports is an issue in all countries. An international systematic review estimated that only 2 to 18%, with a median of approximately 6% of adverse drug reactions, are reported. And that reference is provided for you on the slide. We also know that serious adverse drug reactions and medical device incident reports are important sources of information for identifying emerging safety issues. Understanding the causes and consequences of incidents, including serious ADRs and MDIs, will facilitate the early identification through sharing of information that will ultimately lead to preventing similar situations from occurring. And that is the essence and cornerstone of patient safety improvement. Likewise, setting up systems to facilitate such understanding and communicating the learning across all healthcare actors is crucial. Over the past decade, the Canadian Patient Safety Institute, as a collaborating center with the World Health Organization, has worked with experts worldwide to facilitate the identification of global directions, aiming to accelerate the development and management of patient safety incident reporting systems, as well as the extraction and communication of useful learning to improve patient safety globally.
1 minute, Marianne.
Thank you, Christopher. Reporting systems, previous slide, please. Thank you. Reporting systems, frequently referred to as reporting and learning systems, capture patient safety concerns, hazards, and/or incidents, and are meant to trigger action, facilitate communication, response, learning, and improvement in the system. Establishing a reporting system and processes to support it, including identifying and spreading learning, is foundational to patient safety and incident management and essential to advancing a patient safety culture. In healthcare, patient safety incidents impact the lives of patients and families, as you've heard during Marianne's presentation, as well as providers and organizations. In recent years, considerable focus on patient safety has been aimed at different levels. The culture of patient safety within health organizations, so ensuring that leaders set the tone and climate that enables people to speak up and report, the knowledge associated with patient safety, analysis of safety incidents, and reporting, learning, and communicating these with others. Exchanging and sharing of knowledge, best practices, and experiences has been at the essence of this work through the Global Patient Safety Alerts Initiative. The underpinnings of this initiative is to ensure that patient safety incidents are shared globally and to mitigate and prevent further occurrences. The Health Canada mandatory reporting system and processes are developed with the same principles to ensure serious ADRs and MDIs are identified and reported within a time frame that allows for early identification, appropriate analysis so that the learnings can be fed back for system and organizational learning, and improvement in patient safety and outcomes. So with that, I will pause there. Thank you, and turn things back over to you, Christopher. Thank you.
Great. Thank you so much, Marianne, for that introduction. We are delighted to welcome next Medication Safety Specialist Ambika Sharma and VP Operations and Privacy Officer Sylvia Hyland, both from ISMP Canada. Thank you both for being here today. Ambika, why don't you take it?
Great. Thank you, Chris, and thank you to CPSI for inviting us to present on this webinar. We'll be moving through the content quite quickly to allow for questions at the end, so I wanted to let everyone know that the slides that were previously presented, as Marianne mentioned, as well as those coming up by ISMP Canada, were pulled from the 4 PowerPoint modules available at the link on the bottom of this slide, so you can access them anytime. This conceptual model ties all the modules together. So the first one is an overview of mandatory reporting requirements. The second describes reporting to Health Canada. The third offers strategies to promote and support reporting. And the fourth describes Health Canada's review of those reports and communication of their safety findings. So Mark already gave an excellent overview, but I'll get into some of the highlights of the mandatory reporting requirements and answering some of the common questions that we've received. A key question is who is required to report, and the answer is hospitals. The onus is on the hospital to define the roles of the healthcare practitioners within that hospital, to implement any necessary supports and systems, etc., and it's all to facilitate getting serious ADR and MDI reports to Health Canada. The definitions of serious ADR and MDI are crucial because that's what we'll all keep coming back to as we ask ourselves, is this adverse event reportable? Health Canada wants to know about all serious medical events. If a serious medical intervention in an ER, for example, prevented one of those outcomes listed for serious ADRs, practitioners must use clinical judgment to determine if it should still be reported. Of note, the MDI definition includes actual and potential harm as reportable, because they do include could do so were it to recur at the end of that definition. In hospitals, medication histories and medication reviews often include all types of health products, so prescription, non-prescription, and natural health products, but it's important to note that mandatory reporting does not apply to natural health products, although voluntary reporting is encouraged. Additionally, routine vaccine programs already have a system for reporting reactions, so it's really all other vaccines that are included here. And to gain the most knowledge, Health Canada does encourage hospitals to report even if there's some doubt about whether the product is within scope of the regulations. Medical devices can be divided into 4 classes, ranging from hospital beds in Class 1 to bone grafts in Class 4. And these examples are provided for interest only because all classes of medical devices are included in mandatory reporting. Another key question is when must hospitals report? And it's within 30 days of first documentation of the serious ADR or MDI. So the day it's documented is day 0, then it has to be submitted to Health Canada within 30 days. And remember, Health Canada isn't requiring a full investigation within 30 days, only the information within the control of the hospital. So what's meant by that? Essentially, the information is reasonably accessible within the hospital. Of course, it would be great if additional information could be retrieved, like perhaps recent medication changes at the long-term care home before the patient got to the hospital, but it is not required that you do so. And these are just some examples of documentation within the hospital. So the first of these would count as day 0, because it's documented, and then it needs to get to Health Canada within 30 days. There are specific reporting forms for hospitals to report serious ADRs and MDIs to Health Canada. These forms can be printed off and faxed or mailed in, but if you want to set up a secure electronic submission to Health Canada, you can contact them directly to work out the logistics. And the following 2 slides are images of the new reporting forms which clearly denote which data elements are required. So this is the reporting form for serious ADRs. And remember, the hospital must submit 1 report per patient. So even if the same drug affected multiple patients, the hospital would need to submit multiple reports. And this is the reporting form for MDIs. And for both forms, there is an option to submit a follow-up to a previous report if more information has come to light. So it's important to note the reference number from the previous report to keep everything connected so that Health Canada can make those links. And now I'd like to turn it over to my colleague, Sylvia Hyland, who is the Vice President, Operations and Privacy Officer at ISMP Canada.
Great. Thank you, Ambika. And as you mentioned, I would like everyone to know that all of my slides were selected from the 4 modules that are available and downloadable and modifiable from the CPSI website. The educational approach recognizes that selected content in the slides will be helpful depending on the audience when communicating or when providing education to support your next steps with mandatory reporting. So in this section of the webinar, I will briefly share some ideas and strategies, including initiatives from across the country, so that we can learn from each other and benefit from the early work. In the modules, we provide self-assessment questions to hospitals to guide implementation processes, including, for example, do you have systems already in place that can be leveraged to facilitate documentation and reporting of serious ADRs and MDIs? Is your culture supportive of reporting? Are reporting mechanisms included in your orientation or education programs? We also provide suggestions that you might want to consider, such as creating a multidisciplinary team, identifying individual champions that can help lead this work in your organization. We also suggest utilizing existing networking opportunities to support collaboration and shared commitment. So, for example, we recently learned that a group of hospitals in Quebec are using existing or creating new communities of practice to work together on their next steps. So, as I mentioned, we provide leading examples in the slides, and we selected a few for you today. In Alberta, there is a centralized approach, and we will be hearing from the team in Alberta about their work later in this webinar. In British Columbia, the Patient Safety and Learning Centre is leading a provincial strategy, together with partners, to use their province-wide incident reporting system to report both ADRs and MDIs. And in the modules, we provide some additional details of this work, including screenshots of the reporting pages. In Newfoundland and Labrador, the 4 regional health authorities are working together and have established a provincial steering committee that includes representatives from quality, patient safety and risk management, as well as pharmacy, biomedical services, and information technology. In Quebec, CHU Sainte-Justine has created a collaboration between the pharmacy and health records department for their ADR reporting. There is a pharmacovigilance coordinator who manages the reporting and also reviews and disseminates the risk communications from Health Canada back to individuals in their organization. And this work leverages the coding that is done in health records, coding that occurs as a standard process in the health records department. We include a few slides about the technology options that can be leveraged to facilitate reporting, such as the use of electronic health record, incident reporting systems, and also pharmacy information systems. We also provide tips on the fields that you might want to include in your technology systems as you move forward to facilitate reporting, such as the drug identification number or the device identifier. We also build on the earlier example from Quebec, and we share information on the modules that might not be well known to all team members in the hospital about the work that health records departments across Canada do to capture information that can assist with perhaps tracking the reporting of serious ADRs and MDIs. We share additional details about the actual codes, and we also note some current gaps to be aware of if you're going to be using this process in your organization. The coding, for example, does not capture all of the details required for reporting, and this is why in Quebec the work is done in collaboration with pharmacy. We include suggestions for education and the opportunity to provide consistent messages about the mandatory reporting requirements. And as we heard from Mary Ann Murray, there is also a Patients for Patient Safety Canada module for the specific audience of patients and families, with selected content that is valuable to them. The module provides the key messages in plain language, and we encourage you to also consider sharing this additional educational module, perhaps selected content in your communications to patients or in your patient resource section, for example, of your website. In the modules, we provide tips for recognizing a serious ADR or MDI, and we also recognize that many practitioners know this well. However, it can be a helpful reminder or helpful information for students. For example, some tips that you could, just to give a few examples of the tips, consider if there was harm from a drug or device, if there is an unexpected change in a patient's condition, or a sudden need for a rescue drug, or a sudden need to stop therapy. And this is my last slide. This is to let you know that we have a 4th module. The 4th module is dedicated to describing the Health Canada communications related to findings from their analysis of the adverse reactions in medical device incidents. The entire 4th module is designed to help bring greater awareness to all the work that Health Canada does in sharing learning back to reporters and Canadians. So thank you so much.
Excellent. Thank you both, Ambika and Sylvia, for your presentations. Please remember that not only are those slides available in the recorded webinar we will be publishing within the next week, but much of the information was taken from the educational modules that you can find on the CPSI website. If you have any questions for ISMP Canada or any of our speakers, please type them into the Q&A box at the side of your screen. Now I would like to welcome the final speakers of the webinar, the co-chairs of Alberta Health Services Vanessa's Law Task Force. Holly Meyer is the Provincial Director of Product Quality and Safety, and Nancy Louis is Manager of Medication Quality and Safety. Thank you both for joining us here today.
Thank you, Christopher, and thank you to CPSI for inviting us here today to share with you our approach to implementing Vanessa's Law in Alberta Health Services. So I'd like to start off with a brief snapshot of our organization, which might help provide a better understanding of our chosen approach. Alberta Health Services, or AHS, is a provincial health system founded in 2008, which brought together 9 regional health authorities and 3 agencies under one umbrella. AHS employs over 100,000 staff and serves 4.2 million Albertans in 650 different facilities across the province. AHS has almost 9,000 acute and subacute care beds, which makes us the largest fully integrated healthcare system in the country. Some of you may already be aware that AHS is preparing to implement a provincial clinical information system. This initiative is called ConnectCare, and it is the bridge between information, healthcare teams, patients, and the future. The foundation of ConnectCare is one common information system that will be used across the province. And this slide just demonstrates the broad scope of the ConnectCare initiative. The size of AHS, plus the ongoing implementation of ConnectCare, has really influenced our approach to implementing Vanessa's Law. We are using a centralized provincial approach, which had to be developed for serious adverse drug reaction reporting, as this is a new process for us. For medical device incident reporting, we do have an existing process that is being refined with consideration of both the new legislation as well as new technology. In AHS, we have formed a provincial multidisciplinary committee, the Vanessa's Law Task Force, which is responsible for coordination of this initiative. Our implementation plan includes a centralized process to receive, review, collate, and submit reports to Health Canada. A large part of our implementation has included a communication plan. The goals of this plan are to generate awareness of the Vanessa's Law legislation, to promote understanding of the importance of the legislation, to convey the importance of reporting, as well as to engage our audiences to make the necessary practice changes. Our communication plan covers both serious adverse drug reactions as well as medical device incident reporting. In AHS, we formed a subgroup of our task force that has developed AHS-specific educational resources, which has included memos, posters, videos, and a learning module. Content from the joint venture modules was selectively used to build our AHS-specific resources. All of these resources are being communicated to our frontline staff through our existing communication channels, and it is all being housed on a single landing page within our intranet. As well, a central email account has been set up as a single point of contact provincially for any questions or follow-up. As I mentioned previously, we are implementing ConnectCare, and the software that we will be using is called Epic. All of our sites across Alberta will be using Epic once we complete our staggered rollout. In terms of timelines, our first site is actually going live on Sunday. The implementation of Epic in AHS has been a really big consideration when determining our workflows for compliance with Vanessa's Law legislation. Serious ADR reporting is being completely integrated into Epic as sites go live on the system. MDI reporting, while not fully integrated into Epic, will be linked directly from Epic as well as from our AHS intranet. On the next few slides, I'd like to focus on the process for serious adverse drug reaction reporting, and then I'll hand it over to Holly to discuss medical device incident reporting. So on sites that have not yet gone live with Epic, our existing online reporting system, which is the AHS Reporting and Learning System, or RLS, will be used as an interim solution. Therefore, during our staggered rollout of Epic, we will be managing 2 concurrent reporting processes for SADRs. On the next two slides, I have some screenshots to share, which will provide a general idea of what our SADR reporting process will look like within EPIC. Please note that the information that I have displayed here on the screen are for test patients only and is not real data. A serious adverse drug reaction form has been created within EPIC, and this form asks the user to consider the Health Canada criteria for serious. Jumped ahead one slide. There we go. If the reaction does meet the criteria for serious, the reporter will then proceed to the note writer, which prompts the user to complete the mandatory data fields that are required by Health Canada. As well, the system will then prompt the user to update the patient's allergy and contraindications activity as appropriate. The process for extracting the reportable data from EPIC for submission to Health Canada is still being determined. As I mentioned earlier, we will have an interim reporting process during the time of transition to EPIC. Our online AHS reporting and learning system is being used to capture the reporting of SADRs within our existing medication or other substance reporting form. Oops. Sorry about the jumping around the slides here. I just want to get back to, so this is the medication or other substance reporting form. A specific reporting panel has been developed to collect mandatory data elements as required by Health Canada, and this reporting process has already gone live as of September of this year, and we've already started to receive some reports through the system. As you can see here on the screen, once the adverse drug reaction has been selected as the medication problem type, the reporter is then prompted to indicate whether the reaction is serious. Selecting these options then opens a separate panel of questions which contains the mandatory data elements. And similar to our EPIC process, we are still working with Health Canada on our electronic submission processes from our RLS system. So both of the SADR reporting processes that I've just described to you are brand new to our staff. So we are learning as we go, and we will continue to revise our processes as we are gaining more experience. So with that, I would like to hand the presentation over to Holly, who is going to speak to our MDI reporting processes.
Thank you, Nancy. At AHS, there's two partner medical device safety teams that handle medical device reporting in two main workflows or work streams, one for equipment or maintained devices, and one for products or non-maintained devices. Unfortunately, when this was implemented about 10 years ago, there wasn't a single mechanism or process that met all patient safety and device reporting needs. So there's several legacy reporting methods, which is unfortunate. It's confusing. These include RLS, Reporting Learning System for Patient Safety, the Equipment Feedback Form, Product Feedback Form, a 1-800 hotline, and an emerging issue report. As I mentioned, that is confusing. Next slide. So we took the implementation of the province-wide EMR and Vanessa's Law as the ideal opportunity to streamline the process and reduce barriers to device reporting. We didn't want to inhibit the proactive voluntary medical device problem reporting already in place by focusing only on the mandatory medical device incident reporting. So we developed an integrated online medical device incident or problem report form. So it has the acronym MDIP. We've added problem to the MDI reporting. This has been rolled out into a single InfoPath form that's linked to the medical device safety team's SharePoint site. The form will eventually transition to a standalone DATIX form, and DATIX is an RLS system. And so then the intake will feed both the medical device safety teams for action and the RLS patient safety data for trending and learning. Sites using EPIC will have a link to the MDIP form on their hyperspace. On every EPIC user will have a link, and then others can submit using the same form with a link through the AHS intranet. Next slide, please. The frontline staff, as I mentioned, will complete the event and device information in the MDIP form. The MDS teams will verify and validate the information, arrange device investigations, And we're currently reporting to Health Canada and manufacturers using some custom workflows we have in our system. And we are, as is the ADR team, we're just beginning to work with Health Canada on developing a systematic method and mechanism for transferring the MDI reports, MDIP reports, to Health Canada. Next slide. Finally, we hope to further reduce barriers to MDIP reporting through advances in technology that link the patient EMR data with device identification through scanning. First of all, we would like to minimize re-entry of device information by somehow connecting barcode scanning and pulse from our EMR device registry using unique device identifiers when that becomes available, and eventually move to real-world evidence generation through the technology and linking of the systems. We actually have developed 2 supply wasted codes, or reasons that a supply or device may have been wasted, specific to device incidents or problems used during your procedure. A nurse can select one of these 2 special codes when a device problem is suspected or an incident has occurred. And then this will act as a flag for the MDS teams to follow up with the OR staff about that procedure. This is as yet untested. We haven't implemented this yet, but we hope that it might be one small way to reduce barriers to reporting.
1 minute, Holly.
And that's it for my section. Thank you.
Well, thank you very much. Sorry for interrupting you then. But I do want to offer my sincere thanks to you, Holly, and to you, Nancy, and each of our speakers for these wonderful presentations. Now, I would like to open up the question and answer section with questions we've received in the chat box. I would, however, like to welcome subject matter experts from Health Canada who are joining us to answer questions. Manager of Public and Regulatory Affairs Outreach of the Health Products Surveillance and Epidemiology Bureau, Paul Litowitz. Medical Device Mandatory Reporting Lead, Colleen Turpin, and Regional Coordinator for the Canada Vigilance Program, Elizabeth Potasnik. I would also like to draw your attention to the polling section at the right-hand side of the screen, where we will ask you to give us a little feedback on the webinar today with our thanks. I would like to open up the questions, perhaps starting with you, Elizabeth. We got a question from David Phillips saying that they are an ambulatory cancer clinic and treatment center. Providing chemotherapy, they have many ADRs, which are expected to a degree as they are highly toxic. His question is, does this reporting apply to their centers and all of their hypersensitivity reactions?
Thank you. Can you hear me?
Yes, indeed we can.
Okay. If their facility is defined as a hospital, then under the regulations, they would be required to report serious adverse drug reactions that their patients are experiencing. So if the hypersensitivity reactions fall into the category of serious, then yes, they would be reportable.
Right. Thank you so much. I do have a follow-up question for you, Elizabeth. This one from Fatima. Some ADRs are expected, like febrile neutropenia, with systemic chemotherapy. Is this a reasonable expectation that hospitals report all admissions related to febrile neutropenia?
Again, if the reaction is serious, and then yes, it would be reportable. If it requires hospitalization for treatment, then that would fall under the definition of serious.
Excellent. Thank you so much, Elizabeth. The next question we have is for Paul. Sherry asks, there needs to be some clarity around the word mandatory. Vanessa's law states there is mandatory reporting for the organization, but not mandatory reporting for by the staff of those organizations. Can you help us parse the word?
Thanks for the question. And I'm joined here as well with several colleagues also. Yeah, so the mandatory reporting of serious adverse drug reactions and medical device incidents originates in the Food and Drug Regulations now, as published in June. So, and the regulations obligate hospitals to report ADRs and MDIs. From there, we and you can see through guidance as well that Health Canada has published, encourage hospitals to set up procedures for their staff for medication management standards. And I'll also just connect with my policy colleague, Jeremy Butter, who's in the room with me, to see if there's anything to add.
Yeah, my name is Jeremy Butter. I'm a policy analyst, and I've been working here at Health Canada, and I've been working on mandatory reporting regulations for the past 2 years. So I just want to specify that the legal responsibility for mandatory reporting rests entirely with the hospital. It does not rest with healthcare professionals. So it'll be healthcare professionals who will be diagnosing ADRs and MDIs, and other staff who will be possibly documenting it and submitting reports to us. It is up to hospitals to determine which their internal procedures for reporting and which staff will be doing what. We do expect a healthcare professional to be doing the actual diagnosis, but after that, for the administrative processes, it is up to hospitals to determine which staff they want to do that. But the legal responsibility for reporting is not on any staff. It is on the entity. It is on the hospital entity that the requirement is.
Great. Thank you so much, Jeremy. So it does sound like every hospital will be able to administer its own process. So that liberates it to a degree. My next question here is for Colleen, actually. Will situations where staff or workers have a serious injury related to the failure or malfunction of a medical device be subject to mandatory reporting? Is the expectation that they'll be reporting these medical device incidences to Health Canada as well? Colleen, are you there with us? I just want to check to see if you're muted. You are muted right now, Colleen. All right. Perhaps we'll come back to that question once we get Colleen active on the line, and we can go to a question for Sylvia, actually, at ISMP. Ramesh asks, does ISMP Canada provide training to students to help them learn how to detect serious medication and medical device incidents?
Oh, wow. Thank you so much for that question. So in designing the modules, we included tips in the modules on identifying a serious ADR or an MDI, with the idea and the design that any educator could then take those tips, take those slides, and use them in their education. For example, a nurse educator in a hospital or a professor at a university. And the idea would be that the educator themselves would add on and build on their own expertise specific to their audience. So, for example, we would envision that a medical audience would get from their medical educator some extra information on how to approach this within their field and expertise. And it would be slightly different maybe for the pharmacy students, the nursing students, specific information for respirologists, and even dentists that work in hospitals. So the idea is to use these slides, use these tips as building blocks and help you with consistent messaging, and then build on that for your own specific audience, how to help them specifically in their role identify ADRs and MDIs. So I hope that's helpful.
Perfect. Thank you so much, Sylvia. So really start with those educational modules, and then you can always give the feedback. You can always reach out, because we will be there to support all four of the partners for the joint venture program. I believe Colleen has joined us now. So if we can return to that question, do you remember the question, or do you need me to repeat it, Colleen?
How about you repeat it again?
You bet.
Sorry, I was looking for my unmute and my screen was frozen.
Not a problem. Technical solutions and technical problems. The question was, will situations where staff or workers who have a serious injury related to the failure or malfunction of a medical device be subject to mandatory reporting as well? Is the expectation that the staff will report, or the hospital, I guess in this case, will report these medical device incidents to Health Canada as well?
Yes, thank you, Christopher, for that question. So right in the definition, we actually included that the serious deterioration or death could happen to the patient, user, or other people. So it actually, in the definition, it actually talks about people being involved with medical devices, so the users, or even potentially a family in a hospital that would be maybe electrocuted or something by a medical device. So it's not only related to the patient or the staff. It could really be anybody who is impacted by the medical device. So we have included this discussion in our guidance document, and I believe some of these references will be provided to you, the participants. And just to give you another example, is if there was some sort of lighting fixture or monitor in a OR situation and there wasn't anybody in the surgical suite, however, the whole apparatus fell down and potentially that would have created serious harm for the patient or the surgical team underneath that apparatus. So that would be an example of a near miss to the patient or the surgical team. Or an actual event potentially would be some sort of orthopedic saw, the blade, flies off and cuts the surgeon, very badly, but doesn't impact the patient. So then the impact would be to the physician only.
Right.
Serious harm.
Great. Thank you so much for that, Colleen. That's a wonderful answer. We do have a double-barreled set of questions for Paul coming back. Fatima's back on asking, what is the penalty for not reporting?
Hi, Christopher and Fatima. Thanks for the question. Just to give some context as well, the primary objective of Health Canada's, and this is with regards obviously to mandatory reporting by hospitals of serious adverse drug reactions and medical device incidents, our primary objective is with compliance and enforcement to manage risks to Canadians using the most appropriate level of intervention, proportional risk posed to the public. So for the purposes of compliance monitoring, we're implementing an oversight mechanism to verify reports are being received and that they're complete and provide information of sufficient quality to meet these new regulatory requirements. If a situation of noncompliance is identified, we'll work with hospitals to help them meet the mandatory reporting requirements under Vanessa's law, building on the guidance that's available with outreach and education efforts and address any issues that might lead to future noncompliance. If we identify instances of more persistent noncompliance, additional compliance and enforcement measures could be taken by our colleagues in the Health Products and Food Branch and from our colleagues from the Regulatory Operations and Enforcement Branch using our department's risk-based approach. That's detailed in Policy Online 001. It's the Health Canada Compliance and Enforcement Policy. In the unlikely event that a situation of noncompliance is not resolved through that approach, we could, of course, use provisions of the Food and Drugs Act and associated regulations, for example, seeking an injunction under Section 21.5 of the Act to compel a hospital to comply with the regulations. But in determining the appropriateness of exercising enforcement powers, the department would take into consideration whether the noncompliance of a hospital was shown to pose a serious risk to Canadians, as well as those other factors in that guidance mentioned, or the policy mentioned, 001. So again, our primary objective is to manage risks to Canadians using the most appropriate level of intervention proportional to the risk posed to the general public.
Gotcha. Thank you so much for that. So there are an array of tools that are there, but really it is an open approach kind of thing, not immediately penalizing or anything like that. I do want to follow up with that question. We have mentioned hospitals a number of times. Courtney Miller was wondering, what do home care organizations need to report?
And thanks, Christopher, and thanks, Courtney, as well. A great question. So if the facility is not defined by provincial territorial legislation as being a hospital, then the reporting would not be of serious adverse drug reactions or medical device incidents would not be mandatory, would not be an obligation according to the regulation. That said, for all Canadians, healthcare professionals, and others, we encourage voluntary reporting of not just serious adverse drug reactions and medical device incidents, but medical device problem reports, as well as adverse drug reactions also. For home care or other facilities outside of this legislation, outside of the scope of this new legislation, Health Canada is appreciative and interested to find out about these signals that are coming up and encourage you to report through the Canada Vigilance Program. Jeremy, I don't know if there's anything we might add or
No,
all right. Beautiful. Thank you very much for that, Paul. I appreciate that. I do just want to remind our listeners that on the right-hand side of your screen, at the very bottom, there should be a polling tab. If you could click on there and just answer 2 quick questions about this webinar while we finish up with the question and answer period, that'd be fantastic and give us feedback to be able to move forward. Marianne Murray, I do have a question that came in. Where would we send a member of the public who wanted to file an ADR or MDI report for an incident that happened outside of a hospital setting, maybe in a nursing home like Paul was mentioning? Where would we send a member of the public?
Thank you for that, Christopher. The public can go, or any provider can go to the CPSI website, and under the tools in that website, you'll find that there is a public module that will explain to the public and also provides directions on how they can report an incident themselves. So it really helps for those who experience an adverse drug reaction or a serious adverse drug reaction outside of an institution to have a way to share that reaction and add to the data.
Beautiful. Thank you so much for that, Marianne. I see that we have time for one more question, so perhaps I'll hand it to Paul to bring us home. Paul, can you tell us what kind of information will be shared back to hospitals and provinces further to what they are reporting?
Thanks for the question, Christopher. So as far as what kind of information will be shared back to hospitals after they've reported, we're committed to sharing knowledge gained from the reports that are submitted from hospitals and all Canadians. So already Health Canada shares this information publicly through various mechanisms, such as safety summary reviews, risk communications, an annual trends report that we provide as well. There's also databases that are available, the Canada Vigilance Adverse Reaction Online Database, which contains information about suspected adverse reactions that have been reported from all sources. Recently, we've developed a public-facing searchable online database for medical device incidents. The department also produces a Health Product Info Watch, a monthly publication intended to alert health professionals and consumers about potential signals to detect through the review of case reports submitted to Health Canada. We disseminate findings to healthcare professionals and the public to alert them about identified health risks. We're also undertaking additional efforts as well now with mandatory reporting. We've launched, some of the participants today might be aware of the webinar series that allows for timely sharing of information from the department. We've actually are planning a webinar Thursday, November 7th, 11 a.m. Eastern Standard Time and 12:30 p.m. Eastern Standard Time on systems. So all of our mandatory reporting contacts, or all of those self-identified contacts from hospitals, may have already registered, and if they haven't, they can reach out to hc.canada.vigilance.sc@canada.ca to register for Thursday, November 7th Systems Mandatory Reporting Webinar. Those are a number of the things that we have undertaken and are adding on as well to hopefully help share information back.
That's fantastic. Thank you so much for that, Paul. And we'll make sure that we share that link to all of the participants in the webinar as well. So just in case you want to register for that Health Canada webinar coming up. I do see we are at time, however. We want to respectfully thank Mark Mess, Marianne Murray, Marianne Darpino, Ambika Sharma, Sylvia Hyland, Nancy Louie, and Holly Meyer for sharing their time and expertise. Thanks, of course, to all of you for taking the time to attend. On behalf of me, Christopher Thrall, technical host Barb Laforte, and the rest of the team at the Canadian Patient Safety Institute. Thanks again to our sponsors, Gojo Industries and Health Pro. If you want to continue the conversation started in this discussion, please feel free to send us an email. We will forward your comments and any questions you may have had that were unaddressed onto our speakers. You should all receive Barb Laforte's follow-up thank you email in your inbox shortly, and you can respond to that. We will also post a recorded copy of this webinar on the CPSI website in the next week or so. ConquerSilence is here to stay. This week launches a multi-year effort to inform people across Canada about the silent epidemic of preventable patient harm. and to equip everyone with ways to stay safe. Donate your voice to help us spread the word at the brand new site ConquerSilence.ca. You can listen to our brand new podcast and download tools to help you conquer silence at PatientSafetyWeek.ca. Please make sure to fill out the brief poll questions to the right-hand side. Until next time, have a wonderful day, everyone, and we look forward to seeing you again soon. Happy final day of Canadian Patient Safety Week.